Recording in progress.
Hello, good evening, everyone. Thank you so much for joining us on this very sweaty Thursday evening. I hope you're all okay and have your fans ready for the next hour. We're delighted to have Piril Sideras, one of our advisory contributors, joining us this evening for a webinar on treatment readiness in regenerative aesthetics. So this is all about why the outcomes start before the injection and what you should be doing to pre-treat patients and get them in peak condition to absolutely optimize their results from regenerative treatments. So before we get started, we just wanted to find out a little bit about you and your current experience. So there's going to be a couple of polls popping up on the screen at any second. And if you don't mind filling these in, please. So if you can tell us what your medical profession is, please. Thank you. Lovely. We have got 50% nurses, 17% doctors, and 33% other. Okay, that's great. And the next question should be popping up in a second. And this is just to find out a little bit about whether you currently have a pre-treatment protocol in place. So just a simple yes or no for this one. Here we go, lovely results coming in. And yeah, and that's good. The majority of you don't have it one in place, so you're in the perfect place tonight to learn what a good protocol could look like. And for those of you who answered yes, then the next question is on what type of things you do before treatment. So it should be coming up any minute. So how do you currently assess whether a patient is ready for biostimulation? So is this clinical examination only? Is it involved taking a medical history and lifestyle assessment? Structured consultation questionnaire? Let's see where we are. Okay, so majority of you then are doing a good medical history and assessment of lifestyle, as well as utilising questionnaires. Okay, thank you so much. That's really useful. I'm now going to hand over to Piril, who will take us through tonight's webinar. If you do have any questions, then pop them in the Q&A at the bottom of your screen. If you can't see it, press more, and you should see it at the bottom there. Once the presentation is finished, we'll run through as many questions as possible before wrapping up at 8 p.m. So thank you, and over to you, Piril.
Thank you so much, Chloe. So good evening, everyone. Today we've got a jam-packed presentation. Hopefully we will get through it all, but I really want you to take away a lot of things from this presentation today. And really a quick introduction about me. My name is obviously Piril Sideras. I've been a pharmacist for the past decade, and I still keep a foot in clinical NHS work as a senior clinical pharmacist prescriber. I have founded my clinic, Piril Sideras Aesthetics and Skin Sanctuary, and this year we actually celebrate 8 years in the industry. So all of that and title aside, some of you might be wondering what a pharmacist is doing, presenting in a world of aesthetics. I don't actually think it's an unusual pairing. I think it's an underused one because a pharmacist is trained to ask what's happening inside of the body before we reach for a product. And that's exactly the type of question aesthetics tends to skip. So what we're looking at today is where better outcomes are hiding, and that's what we're all about. Now, in terms of regenerative treatment, I want to ask you all, how many of your treatments have turned out exactly the way you expected? And let's be honest, most of us have had patients who, for example, one patient is absolutely thrilled with their polynucleotide results, and yet the same treatment in another patient, completely different results, and they're not entirely happy and can't see a difference at all. The same product, the same protocol, yet opposite experiences each time. And it's often tempting to explain this to say it could be technique, or it could be expectation management, or it could just be a difficult patient. But this is the pattern pretty much every injector that I've spoken to quietly recognizes, and the one we rarely account for. And the question this presentation answers is pretty simple. What actually separates the patients who respond from the patients who don't? So today there is a long list of things we'll cover, but first I want to talk about the shift that's happening in our field. Then we'll get into the science of how PLLAs, CAHA, and polynucleotides actually work. And then one step that they all quietly depend on. From there, we'll look at panels. We'll look at three simple blood markers that tell us whether a patient can actually deliver that step. And then we'll put it all together on a real patient of mine. And we'll finish off by talking about how you can bring this into your own consultations. And of course, within your scope and without it turning into a burden. So let's start with the shift. Before we get anywhere near bloods or biology, there's something already happening in our field, and it quietly changes the rules of how we should all be working. Let's go back. Well, now if you look at our field, it's grown immensely and it's really moved through three different phases. It started off with procedures, and honestly, most of us are trained right here. You pick a product, you perfect your technique at the nth degree, you judge the result, and that's the foundation. But then we've had a shift, and this is where advanced practice sits now. This is the regenerative work. We're not just filling patients, we're working with their own biology and asking it to be rebuilt. And at the frontier, and where the direction is heading, in my opinion, is functional and longevity medicine, treating skin aging as a visible sign of what's going on in the inside. And our presentation tonight is actually in between the shift and the direction we're heading to in the future. Most of us are taught how to get a good result. We focus on the product, the plane, the volume, the technique, and don't get me wrong, I've done it as well, and all of that matters. It's a real skill that we have to perfect. But if you notice what every single one of them has in common, they're all about what we do. Not one of them is about the patient who actually has to respond to it. We've optimized everything except the patient. And in regenerative work, that's one thing that quietly decides whether it works at all. Now, before we go any further, I want to be really clear about what we mean when we talk about regenerative treatments, because it's a thing entirely different. Think about filler, for example. With filler, the product is the result. You place a volume, that volume is the correction, and your body just hosts it. It holds on to it. It's pretty simple. But regenerative treatments don't work like that at all. The product isn't the result. It's essentially an instruction, and we're not placing the correction. We're asking the patient's own cells to build it over weeks, over a period of time, out of their own raw material. And that's the whole shift in basically one sentence. The moment the patient is the one building the result, the patient's biology stops being a detail in the background and becomes the thing that decides the outcome. And this is really interesting. I want you to take away this really from this first section is the product provides the instruction in regenerative aesthetics, but the patient provides the response, whether that's PLLAs, CAHA, polynucleotides. None of them are the collagen. They're essentially a signal. And that collagen itself is built by the patient's own cells. And that right there is why you can use the same product with the same hands and get a completely different result every single time. It was never really about your technique as such. It's about whether the patient sitting in front of you is ready to respond. So let's actually get into a bit of the science. And I love a bit of science because I find it super fascinating. And there's three very different treatments. And once you see what they're each doing at a cellular level, you start to notice they're all quietly utilizing one same process. The three regenerative treatments we're following today, and really the sort of bigger names that we know in the industry, your PLLAs like Sculptra, your CAHA, Readiness, and then polynucleotides. And the thing I want you to notice is that they all come from completely different doors. The PLLA works by provoking a controlled foreign body response. CAHA will bring an immediate scaffold and then recruits a collagen cascade that happens. And polynucleotides work further upstream, again, signaling directly to the fibroblast and calming down inflammation. So three very different entrances, but the whole argument today that I'm building is that they have one common thing in process. We look at the process, the particles go into the dermis, and over the following days and weeks, the body gradually breaks them down, and it's that breakdown that does the work. It triggers a controlled immune response. The macrophages then shift into their healing. You've got an M2 mode, and through a signaling called the TGF beta, they switch the fibroblast on to start laying down new collagen. This isn't a filler doing the work as such, it's the patient's own collagen switched on by the product. So what you're really looking at weeks later is the patient's own biology made visible. And that only works as well as that biology allows. Readiness does something similar, but it starts from a different place. The calcium microspheres give you an immediate lift and physical lift on the day, but then the body reacts to those microspheres by recruiting, again, similar pathways of macrophages, fibroblasts, and they start laying down around them over time. So you get two results in one, essentially, the immediate lift and then a slower biological one underneath it. And that is the second part, the collagen the patient builds, that again depends entirely on the machinery we're about to get into. Polynucleotides are the most upstream of the three. The polynucleotides themselves get broken down into nucleotides. Then those nucleotides signal to the fibroblast again through the A2A receptors. And that does three genuinely useful things at once. It calms the inflammation down, it encourages new blood vessel growth, and it also pushes the fibroblasts to produce more collagen, elastin, and fibronectin. And there's even a salvage pathway, recycling those nucleotides to fuel the whole thing. So again, polynucleotides aren't really filling anything. They're turning up the patient's own repair machinery and asking it to work harder. Now, we've looked at three different products and going in through three completely different doors. And yet, if you follow them each downstream, they all end up in the exact same place. The fibroblast gets switched on and it starts making a pro-collagen chain. But here's the thing, the chain isn't collagen yet. And before it can become real, stable collagen, it has to go through one specific step called hydroxylation. And this is the part that no one really talks about. Every single one of these treatment drivers drive more traffic into that one step, and not one of them supplies what that step actually needs. They all converge on it, but they're all blind to it. And what is that convergence step? And this is it basically in one diagram. Three treatments at the top, three different machinery, but in the middle, they all funnel down into the fibroblast and into this one step, hydroxylation, done by two enzymes. Now, this step depends on two cofactors, iron and vitamin C. Vitamin C matters, and it's something we do to support. It's easy to keep topped up, so it's rarely the thing that holds a patient back. But iron is very different. Iron is one that is so commonly depleted, especially when we're in NHS world. Everyone is depleted on iron. And that is something that we don't really check in the aesthetics world. And it's the thing that quietly depends on us being able to produce collagen, whether it matures into strong, lasting collagen or just gets broken down. That is decided right there. And that's the step we're deciding to target. So if that one step, hydroxylation, is really what decides the result, the honest question is, can we tell before we ever treat whether a patient has what that step needs overall to work well? Because right now, most of the time when we're injecting in clinic, we're just guessing. We think it's the right product, but we're just guessing what the outcome would be. We treat, we find out afterwards. And this whole section is about whether we as practitioners can do better than that. Now, the thing that I've just shown you, the macrophages, the fibroblasts, the hydroxylation step, the iron, all of it is obviously clearly invisible to us. You can't see any of it in the chair. So two patients can sit in front of you, almost identical, same age, same skin concern, and underneath biologically be in completely different places. One is set up to build, one isn't, and there's nothing on the surface that tells you otherwise. And right there is essentially the reason why we're looking at this. We're not just, looking at whether they can in front of us. From a clinical point of view, we want to look deeper. And the real question is, can we look deeper? Now, the body keeps a record and we can look a bit deeper. And all of this internal biology leaves a trace in our bloods. So a marker is really just that. It's a readable signal that's standing in for something we can't directly see. So we've genuinely got a choice. I believe as practitioners, we can treat and find out afterwards whether the biology was ready, or we can read the signals first, know before we start, and this is the whole case for running a panel, is that it turns essentially the concept of, is the patient ready to respond from something we guess at into something we can actually read. I'll be upfront about this because this isn't about ordering every single test under the sun. I've kept it deliberately tight, and these three markers really earn their place, especially when we're talking about regeneration: ferritin, vitamin D, and HbA1c. And then two more we get to read for free because they're already sitting in a standard panel. We get transferrin saturation and a ratio called the neutrophil to lymphocyte ratio that we can actually work out ourselves. And that's the whole panel. That's all I want for you to focus on. It's not about more tests, it's about reading the right ones properly. And each one of these three is actually telling you something completely different. So let's go off with ferritin. Now, because out of all of the markers, this is the one that sits closest to the actual rate limiting step. Those hydroxylase enzymes need iron to do their job. So if a patient's iron status, it's not a nice to have, it's the cofactor the whole process depends on. And the part that I find really interesting is that when iron is low, the patient is still making procollagen, the signal still fires, the raw material still gets made, but what suffers is the finishing product, whether that procollagen matures into something strong, a stable collagen, or just gets broken down very easily. So a low iron, it doesn't just dent the response a little, it means that the collagen that forms is less likely to last. The one caveat I always want to flag, and it's exactly why transferrin saturation is important on this slide as well, is that ferritin is your iron stores, but it's also an inflammatory marker. So when there's an inflammation around, it gets pushed up. But a patient whose stores are, in comparison, genuinely depleted, can come back with a ferritin that looks completely normal. So transferrin saturation gets around that because it tells you how much iron is actually available and in transit right now. So I read the two together as a cross-check because if the ferritin looks fine but the saturation is low, that's the classic masked picture, the inflammation propping up while the patient is actually short on iron. So one number on its own can mislead you, but reading the two together can produce a far more reliable response. Vitamin D is a different kind of marker. It doesn't sit on the enzymatic step we spoke about, that is similar to the way that iron does. It doesn't do that. It essentially sets the condition the whole process runs in. It supports the anti-inflammatory side of repair. It helps the macrophages move from their early inflammatory mode into a healing one. And when it's low, the patient is essentially running a bit on the low-level background inflammation, and the repair response is blunted from the start. So the way I'd word vitamin D is it's kind of an immune modulator. It conditions the response rather than being the rate-limiting step. The NLR also is important in the same blood test. It gives a free read of that inflammatory tone. So typically 1 to 2, non-specific, but it's a useful check to have. If someone, another thing to bear in mind when you're looking at blood panels is if someone has had acute stress or inflammation or a viral infection, these factors will go up. So how they've done the blood test is equally as important. HbA1c is about whether the result lasts, and it reflects about 3 months of glucose exposure. So it's a sustained picture, and it works with you in two places. Well, works against you actually in two places. First, the sugar cross-links, the cross-links essentially make collagen abnormal, and the distinction matters. Healthy collagen is cross-linked too, but in a way that in an organized enzymatic way, like a woven rope. Glycation is more like the rope being glued together. It's stiff, it's rigid, and resistant to healthy remodeling. So it impairs it in that particular sense. The second way it impairs it is through the fibroblast itself, through the age-range signaling. So new collagen is laid into a compromised environment. Now, a raised HbA1c isn't a contraindication. Being diabetic isn't a contraindication, but it's about having an honest conversation about expectations with your patients. And for someone who is pre-diabetic or diabetic and under specialist care, it's a flag worth respecting before we treat. So this is important. And I think that this is really the bottom line. Every reference range on a blood test is built to find disease. Is there something here that needs treating is the question for the GP. And for the GP, that's the right question. But it's not my question as an aesthetic practitioner. By the time someone is in my chair, they're usually already clear. They've cleared that bar. They've kind of already done their checks and they're well. The report says normal. What I want to know is one step further. Are they functioning at an optimal level, or are they functioning at a suboptimal one? Because no disease and working at their best is two completely different things. Someone can be normal as such on every line of a blood test report and still be running suboptimally underneath. And if we're suboptimal, the real question then also becomes, are they actually ready to respond to what I'm about to do? And so this is what those three markers look like on a lab report. For those of you that are, medical professionals and work within the industry, we know what these are. And I've kept the labels exactly as a lab would write them. Deficient, sufficient, normal, pre-diabetes. There's nothing controversial here. And if you sent these bloods off, it's the language that comes back. But watch what happens when we essentially stop reading them for disease and start reading them for readiness, because each one points in a different direction. Ferritin, you need to get above a line. The lab only flags it as deficient below 30, but sufficient in that low band can still be too low for the step that we spoke about with the hydroxylation to run properly. It's not until around 50, and I'd call the stores genuinely ready for active synthesis. So with ferritin, I'm asking, is your ferritin level high enough? Vitamin D has no hard line at all. 50 is where the lab says it's sufficient, but the benefit doesn't switch on there. It keeps building gently up towards 75. So again, I'm not checking whether they've crossed a threshold. I'm asking how far up the gradient they are. And HbA1c runs opposite way to both of them, which is a good thing. This is the one where the good direction is down. The whole green block is normal. Nobody's flagging it. But the lower a patient sits inside of that range, the less glycation they have. It's not going to be stiffening the collagen that I am going to be injecting and wanting to build. So really, same three boxes a GP would read, but three completely different questions. Is it high enough? How far up? And is it low enough? And one of those questions is what the standard reference range was ever drawn to answer. And here's the same idea with one patient. Ferritin of 35 to their GP, that's in range, no disease, nothing to act on, and they're right for a GP or for a medical setting. But I'm reading the same number against a different goal, a treatment that depends on the patient's ability to build collagen. And against that, 35 is below what the step needs. So the regenerative result we're aiming for is the thing most likely to fall short. The same number, two readers, two different answers. And this one that we're looking at shapes our outcome. So step back from the three markers for a second, because they're all really asking one thing. Not is the patient ill? We've kind of crossed that bridge with the GPs asking that question. We're asking what ferritin, vitamin D, and HbA1c all come back to is simpler. Is the patient's biology ready to respond to what I'm about to do? Can the cells complete collagen maturation? Is the environment receptive? Will what we build on hold up over time? Different markers, same underlying question. And when you read them together, the conversation starts to shift. You're no longer hoping the patient responds. You've looked beforehand at whether the biology supports it. And this is what the panel really offers, not more numbers as such, but a way to assess readiness before you start rather than judging it and guessing it afterwards. Now, that's the biology. The question is now, what do we do with it? How does this change the consultation and the decision really in front of you? So if someone isn't ready, what do you do about it? And I want to be super clear about the scope here, because real readiness isn't a supplement, it's the whole functional consultation. Consultations in my clinic take about roughly an hour, and we speak about everything. We talk about their nutrition, what they actually eat, how they sleep, how stressed they are, their lifestyle. We read alongside the bloods, and all of that is a route to readiness. And for that full picture, this is the standard I'm aiming for. What I focus on and the part I can measure and act on precisely is targeted supplementation. So when a marker shows a specific shortfall, I like to correct it if in my scope. And I confirm on a retest that it's actually moved, the bar has shifted, and then I start treating. So the patient I treat isn't one who walked in below the line. It's the same person once their levels are where they need to be. So here's where the blood picture sits in, where the blood profile sits in an actual consultation. A patient comes in, and the first thing is the concern, what they want, and whether it points towards a regenerative treatment at all. And if it does, then that's when bloods earn their place. You either look at what they already have, or you arrange them privately if something in your consultation gives you reason to. Then you interpret, and this is the only real decision on the page, not is it normal or is it ready. If they're ready, you treat and review as you go. But if they're suboptimal, you don't send them away. You correct what's correctable. You keep them moving with surface or hydrating treatments while their levels recover. And then we retest to confirm, and then you can treat. Now, that retest window isn't fixed. I mean, it's set by what you're actually correcting. Iron replenishes slowly, so it's usually a few weeks through a few months. HbA1c can't move faster than about 3 months, so it's an average of 3 months in its very nature. Something borderline might come back sooner, but I'm not waiting every single time 12 weeks. I'm waiting for as long as that specific correction needs. And the blood result never replaces the consultation. It sits inside of your consultation, and it changes one thing: we treat now or we prepare first. I've spent this entire argument, well, in this entire section, arguing we should look at bloods before we treat. So I want to be clear about the limits around it. First, the testing. Every marker on this panel matters really for the patient's own health. Iron, vitamin D, glucose handling, they're all worth knowing regardless of whether they have ever had a treatment. And anything beyond a routine panel is arranged privately through us or through a different supplier, not pushed back onto an NHS that's already stretched. Second, the treating. And this is the one that I cannot emphasize more. I stay within my scope. If a result I'm reading points to something medical, a ferritin low enough to need investigation, a glucose that needs proper management, I refer. I don't treat around it, and I don't treat it. The aesthetic treatments wait until the medical question has been answered by the right person. And that's the whole position we're in. We look at bloods because it makes us better clinicians, and a better clinician who knows which findings aren't theirs to treat. And that's our theory, but the proof, babies, are in the pudding. So let me show you what this looks like in practice in my own clinic. So this is Chelsea. She's 36, and she came to me about her under eyes. A hollowing tear trough, dark circles that wouldn't shift, and a skin that had gone thin and crepey. What actually bothered her wasn't any single one of those. It was how tired the whole area made her look, even on days where she felt like she was fine. And there was one thing in that she mentioned, almost in passing, that she'd been feeling very fatigued most of the time. Right now, that was just a comment on the form. So let's bank that aside. Now, this is something straight out of Chelsea's consultation form in her own words. And the way that I run my consultations matter. The consultation forms are sent to patients prior to them coming into the clinic. She completes them in her own time, on her own, and not sat in front of me, because that's when you get a true reflection of how someone actually feels when they're comfortable in their own space, before any of the in-person politeness starts to creep in. Now, how someone feels about how they look is the real reason why they have come. The tear trough is the what, but dull, tired is the why. And then we talk through it in person, we explore it together, because the form gives me her honest words, and the consultation is where we work out what's really behind them. And two things have stood out here. First, the word she reached out for about her appearance is tired. And this was the same word essentially she used about how she was feeling in herself. So a form alone won't flag that. But in conversation, it's kind of these small little strands you have to follow. The second, when I asked her to score things, her overall appearance came out about 7, but her skin on its own was a 2. So that gap tells me the distress isn't about structure or volume, it's about the quality of skin herself. And so before I ran any single test, I already have a working idea of what I'm dealing with, and the reason why I decided to dive in a bit further than what's on the surface. So let's do a patient assessment. Okay, so this is Chelsea, as we know. She came in, actually, she booked in for a skin booster. She decided before, she decided on the treatment herself. And a majority of us, we get patients that book in what they think they want. And, we haven't worked out the problem. We see this all the time. So what can we actually see? Let's start with the under eyes, that shadowing and hollowing through the tear trough, the thing she came in about, but then going across the cheeks. The skin's a little bit congested and reactive with some patchy pigmentation. The tone is a little bit uneven. That's where the warmth has maybe gone from her mid face. There's early volume loss, a bit higher up in those mid face, the cheeks starting to flatten a little bit and descending, which changes how the light is actually reflecting on her face. Now, on their own, these individual areas, none of them are dramatic. You could pick any one and treat it at the surface, but then you put them all together, the dullness, the reactivity, the lost tone, the under eye. This isn't 4 separate complaints. It's actually the skin that's not being supported from the inside. And that's the moment I stop looking at the face and I start asking what's going on underneath. So I sent Chelsea. Chelsea hadn't been to maybe a GP in a very long time. We asked to do some bloods because of how she was feeling. And this is Chelsea's actual panel, what you're looking at when we pull some bloods. And I want you to bear in mind what actually gets missed here. The ferritin is 22. It's in range. The lab reference starts at 13, so nothing is flagged. Nobody rings her. She's okay. But if you stopped at ferritin, the way most panels invite you to, and most, as working in GP practice, ferritin is something we order all the time. But when you look at this by itself, it sends you down different spiral. So we are looking at the rest of her profile. Her serum iron is low. Her iron binding saturation, the iron actually available to use is 7% against a baseline of 16. And her binding capacity is raised, which is the way the body is reaching out for the iron, but it can't get a hold of it. And that is a textbook functional iron deficiency. In a woman whose ferritin was only measured, it would have been, not a concern at all. So the stores read normal. The working iron tells the real story. And the only reason we caught it is that we didn't just stop at one number the panel happens to flag. And there's a layer underneath this that matters just as much. It was what was actually requested. A lot of GP panels, like we said, only run ferritin. And if that's all, what was ordered for Chelsea, the result comes back as a number 22. It's in range. Saturation bindings were never done. So the deficiency that's right there in front of us now would simply never have shown up. Not because anyone's misread it, but because it was never measured. And that's why when it matters, I'd run a full iron profile. Whether that's with myself, with an external company, I want to see the full profile. And then the two others are genuine strengths. Vitamin D is 97. I mean, that's fabulous, especially in the UK. Comfortably sufficient, supporting the repair environment rather than holding it back. And the HbA1c is 31, low glycation, no sugar loaded on the collagen that she's about to build. So we're good in that sense. So her tissue quality is firm, it's on our side. So we're really looking at one deficiency to correct on a background that's otherwise working in her favor. And that makes the plan super straightforward. So let's translate these numbers for what they mean for Chelsea, because in practice, I have started to get used to seeing people who have low iron and how it presents in our faces. The iron is the one thing that's off, and it shows up exactly where she's bothered. The skin around her eyes is the thinnest skin anywhere on the body. So there's very little covering the vasculature underneath. When the working iron is low, the skin appears a bit paler, and through skin this thin, this bluish tone of vessels beneath start to show through. And that's essentially the shadowing that she's coming in about. And I want to be honest, because under eye darkness really is genuinely multifactorial. It can be structural, could be genetics, could be a little bit of pigmentation. So there's a lot at play. So I'm not saying that low iron is the cause of Chelsea's dark circles. What I'm saying is that there is a clear functional iron deficiency sitting on her panel, and it's also a very likely contributor here, and it's a correctable one. And her vitamin D and HbA are both healthy. So the repair environments on our side, two things are working for us. So one thing to correct and two to build on. So the plan in simple parts. First, the part that mattered most for staying in my lane, her iron deficiency, was clinical. She had a previous NHS sample done. Her iron was fine. They only measured ferritin. We then did the full profile, came up slightly different picture, and I sent her back to her GP because it wasn't my clinical finding to treat. So her bloods were done privately. We identified the deficiency, and we, sent her to the GP, and he prescribed some iron medication. Now, secondly, we wait around 3 months, in my opinion, until her iron studies could be rechecked. Her skin was something she scored low in the consultation, and it was one of the things that bothered her the most. And so yes, we have a period of waiting if we're supplementing, and she came into us for skin boosters for her under eye, and we want to work on her under eye. But when there is a clear border of deficiency, we need to correct that first before we can treat. Now, we use this as an opportunity to work on exactly what she was concerned about, actually far more about her skin health. We designed targeted skincare plans, personalized facials, supported her skin barrier first, and none of it depends on iron that she was short on. So we're improving her skin without asking her body to build the collagen just yet. And then thirdly, once her iron was reconfirmed as replete and the barrier was healthy, we started to treat. We did 2 sessions of Planest Eye, and then we went in with a single booster to refine. We treated the version of her that could actually respond to the thing that we were doing. So the order is really simple. Once her levels were replete, we regenerated first and then we refined. So to be clear on what we've done by this point, corrected the iron, gave her skin, the cofactor it needed to build the collagen. So a lot of the groundwork was already laid before any injecting was done. Then I used Planest Eye across 2 sessions, 4 weeks apart. And that's the polynucleotide doing the deeper cellular level repair, working with the skin that could actually respond to it. The skin booster comes last, and it's there to do a different job. It's there to add hydration to the area where the polynucleotide is already working at a cellular level. And there's a nice advantage to placing it last. You're putting it into skin we've already conditioned and repleted, and rather than tired, depleted tissue, so it tends to integrate better. And in my opinion, the hydration actually lasts for longer. So this is Chelsea, 6 months, well, 8 months down the line, and I want to be honest about what this is, because I know how these can get used. I'm not going to tell you that iron correction alone did this in work in isolation. I won't pretend that it did. What I can say is that the quality of the result and how well it held is exactly what you'd expect when the biology was ready to before we treated. And the argument I actually care about isn't even in this photo. It's the version that didn't happen. where if we treated on day one, iron was still depleted, we would have got a flatter result. We would have got a patient that says, I did a course of polynucleotides and I didn't see a result, or someone you don't hear back from. And it's the easiest thing in the world. You know, we would have blamed the product. We would have said, oh, it was her or whatever it is. And that's the case of why we read bloods first. Not that it guarantees a better photo, but it stops you doing good work into a body you can't answer into. Now, a lot of talking. My darlings, that was intense. But I want us to take a breath for a second because we've covered a lot of ground. And I hope more than anything that this has been, you know, an eye opener, a different way of looking at the person in front of you, not just the concern that they walked in, not just the area we're treating, but the whole picture underneath it. Because once you start seeing patients that way, holistically, biologically, as a system rather than a surface, everything changes. The conversations get more honest, you know, the results get better. You build a relationship with your patients and that care gets deeper. So let me leave you with what I actually love for you to take away from today. The most important 5 points is really one, read before you treat, especially when we're looking at regenerative treatments. The reference ranges we have were built to find disease, not to tell you whether a patient can respond. And that's a different question. And it's ours to ask. Two, the injection is the last step, not the first. The real work is in the preparation. The outcome is decided really long before you treat. Three, when someone isn't ready, you don't turn them away. I don't want you to do that. You don't push on regardless and say, well, I'm going to lose, you know, this customer and they're going to go somewhere else. You explain to them, you educate them, and you correct what's correctable. You retest to confirm it's moved, and then you treat the patient who can now respond. Four, I want you to stay in your scope. We're reading for readiness. We're not diagnosing disease. We're not, you know, when the blood points beyond aesthetics, it's a referral and not ours to manage. And five, this is about care. It's not a sell. Sometimes the most honest thing, or really, you can do is say, you know what, Sarah, let's wait. Let's get you ready. It's the harder conversation and the one really that the patients trust you so much more for. And that's the whole argument, really, that the result isn't only about what you inject. It's about whether the person was ready to respond to what you're about to treat. Treat the biology first, and then the aesthetics will follow. Well, I hope you got so much more from that. Thank you so much. And
Thank you.
lots of references to add on.
Oh, brilliant. Thank you so much, Pearl. That was an excellent presentation. We really appreciate all of your work there. If anyone has got any questions, please pop them in the Q&A at the bottom of the screen and we can get them answered for you. And perhaps I'll start us off. What would you
Mm.
say is one of the biggest red flags that you tell a patient that you spot a patient isn't quite ready for treatment yet?
It really depends. It starts with a consultation. If they're telling you, and I ask a lot of different questions, a lot of different ways of speaking to customers, but you kind of gauge if someone is genuinely depleted, if they are feeling fatigued all the time. They will tend to say these in passing comments. So as a practitioner, you kind of really want to pick these up as you go along and be like, you know what, you've said you feel tired as well as you look tired, so maybe we need to explore this a bit further. And so actually being alert as a practitioner during that consultation and just asking the same question, but maybe different routes to get to, where you want to investigate into. We're like detectives, really.
Yeah, yeah, you are exactly. And I suppose if you've pushed for time and you've only got a couple of minutes extra, if you could only add a couple of extra minutes to your consultation, what would be like the key question that you would get in there?
You know what? Speaking about blood panels, a lot of the time patients already have annual bloods and GP bloods that are being done. When we're thinking about younger patients and population, we don't really check them unless clinically needed. But if you're treating for an older patient, I would ask, have you had recent bloods done? And ask them to send you their result and say, do you know what? It's important for me to have a look at so I can best advise you. Let them go away and think, why is she asking me about my bloods? What's that got to do with me having filler or me thinking
Yeah,
about getting my skin tight? And a few
Yeah.
things I say to them: send me your blood tests, send me a picture of your skincare, and you stay connected. And then when they come back in for another conversation, you can then talk about the blood panels. You can speak about it then and there if you've got the time, or you kind of build that relationship, and that relationship is so important.
Yeah, yeah, it's just keeping that communication going then. It's using like little
Yeah.
tools and questions that keep that communication open. So even if a patient it doesn't quite feel ready, they can keep engaging with you and hopefully learn a little bit more about what it involves to make them feel ready for the treatment, I guess.
Exactly.
Brilliant. Okay, thank you. And final question, and we're doing more regenerative treatments being talked about more and more. What's the kind of advice that you could give to them on not comparing and making it really clear that results are individual and what their expectations should be?
It's really about educating patients about what regenerative treatments are. People, there was a boom on TikTok and Instagram, and everyone's getting salmon sperm. And there is a time and a place for someone to get those treatments. But majority of the time, it's being injected in everyone, same type, everything is same. And actually, individually, we're all so different. So it's about educating them that actually this is going to work with your body. And if we're working with your body, if you're a chronic smoker, if you're eating fast food every single day and you're not looking after your health, you're constantly stressed, you're not going to get the benefits of this treatment. So either we venture down different routes, or we correct what we can correct and we look at optimizing you as best as possible.
Yeah, that's brilliant advice. Okay, thank you so much, Piril. Thank you everyone for joining us. And if you join late in the webinar, we'll be able to keep after be super interesting for them and I and you, Piril, for an excellent presentation.
Thank you so much, Annie. Can't wait to see you at the
Bye.
conference.
Bye.
Bye.
Bye. Bye.